one is going to be more of like more of a wrap up kind of a session. And we'll probably be bringing in some of our podiatry colleagues and wound and vascular, just kind of maybe just review some cases together, and everyone can kind of comment on it, and then talk about, we may try to find some time today to talk about subjects that we want to get covered, because we have to have the curriculum for next year ready to go ASAP. So that would be all things that we are planning. All right. Well, we're almost 12:10, so I'm going to go ahead and let Josette take it from here if she wants to introduce herself and her topic. Unless someone else knows, did Kristen say anything, Kayla?
I'm sorry, what did you say?
Did Kristen say anything?
She hasn't yet.
Okay.
I'll try to call her.
All right. Let's just give them a moment.
I'm going to go ahead and pull up your slides, Gisette.
Okay, thank you.
All right. Kelly, do you want to do like a quick Hollywood Square?
Yeah. Sorry, I'm like, is it going to show up?
It's showing up.
All right. Hello, everyone. So I am Kelly Guthrie, and I am the new program coordinator with the West Virginia CTSI. If you guys knew Elizabeth, she left and went to National Geographic, so I'm just kind of here to fill in for her. It's very exciting, and Jay is at a conference today, so bless his soul. So I'm still learning. There might be some issues. If so, bear with me, but I promise it'll get better. If we want to start out, I'll start at the bottom. Jeffrey, would you like to introduce yourself first?
It's Dr. Addison Michael.
All right.
Yeah, there's
Dr.
no
Michael?
microphone at this location. Sorry. He's a podiatrist at Buchanan at St. Joe's. Helps us take care of patients in those locations.
All right, thank you. How about Kaylee Carpenter?
My name's Kaylee, and I'm a medical assistant and a navigator at Community Care in Marlinton.
All right. Is it Abba Suchek?
Hey, I'm Dr. Suchek. I'm a podiatrist up at Waynesburg and also at Ruby.
All right, thank you. Sorry for mispronouncing your name. Next, we have Jake Powers.
Hi, I'm Jake Powers. I work at Fairmont, one of the podiatrists. I also work at Ruby.
All right. Kayla.
Hey, I'm Kayla. I'm a PA at the Marlinton office, and I apologize for the screaming kids in the background. I just turned on the splash pad. Kristen said that she would be joining shortly. She just finished up with a patient, so she'll be on too.
All right, thank you. How about Rosalie Hopkins?
Hi, I'm Dr. Mintz's research assistant. I work at Ruby.
All right, Samantha.
I'm Dr. Samantha Mintz. I'm a vascular surgeon. I'm the PI of the Vascular and Diabetes Amputation Prevention Project, and also at Ruby.
All right, thank you. And if future note, if you all adjust your names, I will be sure to address you correctly, so I do apologize. And then our speaker today, we will be having Gisette Batsinowski. I still messed it up. So, Gisette, if you would like to start.
Okay. Hi.
I'm Josette Batsenikos, and I'm a nurse practitioner. And I've been doing, well, I did primary care and wound care for 10 years. And I just started doing some cardiology. I just wanted to give you a little educational thing on venous insufficiency and ulcers in primary care, information for clinicians to help their patients and themselves. And I think this might be helpful for providers and really in any specialty because I included a lot of resources on how to get your wound care certification if you're interested in that, and books and journals and websites that can be helpful to you and ultimately to help your patients. So I hope this is helpful to you. I know so many of you are very educated, wonderful people, and you probably know a lot of this, but you can use this lecture, these slides to, help maybe students that you have in the future or whatever you would like. So I hope this is helpful. Okay, you can go on to the next slide. And then the objectives are, sorry, I'm getting old and I can't read. Understand the pathophysiology and disease progression of CVI, identify at-risk patient population, strategize prevention plan for VLUs in primary care, promote, utilize, and share available resources and education for clinicians to become certified in wound care or obtain further education for CMEs in wound care to improve their skill set and to help this high-risk patient population. Boy, and is it high risk? So very quickly, what is venous insufficiency? And we know that normally valves and veins help blood flow back up to your heart. And in CVI, these valves are impaired, causing blood to pool in the legs. And this causes increased pressure in the veins and leads to symptoms like swelling and ulcers. And don't forget that any of the leg veins can be in fact affected, including your deep veins. Edema in the lower legs or the feet, pain, feelings of heaviness, aching in legs or feet, itchiness, redness, they're all symptoms of CVI. I found an article that had mentioned that in a 25-year population study, the average time from CVI diagnosis to ulceration was 5 years. And then in another smaller study, the time it took was 3 years. And although this disease process sounds like it's slow to progress, the damage that's being done silently, is often done before clinicians even realize the evidence of the disease. And, by that time, it can be too late to be preventive, which is always, your goal is, trying to prevent these types of things from happening. And sometimes we're just simply too late. Okay, next slide. So what is the cost of these lovely VLUs? Well, according to Medicare and commercial insurance payers, VLUs cost $14.9 billion annually. And that cost boils down to somewhere between $13,600 to $18,900 a patient. So that's quite a bit when we can prevent it. I found this cool little schematic on faulty valves. I thought that was kind of helpful, might be helpful for education, the healthy vein valves and then the damaged. Next slide. Valve dysfunction, outflow obstruction, arteriovenous malformation, and calf muscle pump failure contribute to the pathogenesis of venous hypertension. And I really like the picture of the leg next to it because this is often what you see kind of in a more advanced state of CVI. Okay. Remember that CVI is a disease and requires treatment. And I also like this little picture. It shows you the stages of vein disease. I think I got this from the British Journal of Medicine, but it shows you the spider veins, the varicose veins, then the leg edema, the skin changes. Seems like that's where we often get them in clinic, is when they have the skin changes, and then the leg ulcers, and that's where you see them a lot in wound clinic. But that is a very good picture. I did not hear this term of phlebolymphodema until I went to a wound care conference. It is now being used more often. And it kind of combines the two, the venous circulation system being impaired and the overload that it puts on the lymphatic system. And the picture is pretty nice too. Whoops. It shows the swelling of one or both legs. The ankles and feet can get this, but as you see, the lower leg does too. The thickened, hard skin, like you see a lot in lymphedema. The changes in the skin color, the hyperpigmentation, and then of course, your open wounds and ulcers. And yeah, it's definitely, that's a term that is being used more often. And a lot of times in my clinic, we would refer it to as secondary lymphedema. And oftentimes you can get your patients help this way with the lymphedema garments or the compression garments, and the venous or the lymphedema pumps. So that's a handy term, phlebolymphodema or secondary lymphedema, to identifying patients at risk. I love cats, so I had to use obesity there. So obesity is definitely an at-risk problem. Sedentary lifestyle, orthopedic issues or poor ambulation, that definitely puts you at risk. Being over 50 and often female, congestive heart failure, varicosities, previous DVT, and other risk factors. These all put you at risk. And clinicians must identify patients and ask questions. We need to examine their legs. That is something oftentimes in family practice we don't do. So we need to do it more. Start with prevention, weight loss, exercise, encourage physical therapy. When you see these problems happening, encourage chair exercises, educate your patients about the importance of moving and, using those calf muscles, and help them find compression or garments that they will wear consistently, because that is really the key, consistency. Next slide. The SEEP classification system. I just wanted to put that up there. That is just one way that you can, that has been used to basically report, like a standardized reporting system around the world. It was actually developed in 1993, and it does provide a comprehensive, objective classification to chronic venous disorders. I'm sorry, I can't talk today. It was updated in the year 2020 to include some additional details. A lot of clinics, a lot of hospitals do use this classification system, but it's good to be aware that to be familiar with it anyway.
If you want any insurance company to pay for any venous intervention, you have to put the CHEAP or the SEEP on your assessment.
Yeah. That's, yes. And you're right. There are some other, and also there are, with Medicare, there are lots of other little hoops to jump through in your documentation to get compression stockings and garments as well. Like, you have to document about exercise and various things. But usually if you get connected with a garment company, they will help you, kind of with the kind of wording and the different things that you need to document. They kind of help you get through those hoops, which is nice. Yeah, but you are right. Yes, they do require those things. Anything else, Dr. Mintz, that anything else that you can think of that you'd want to comment on right now? Because your opinion and your input is super valuable. Okay, skin conditions. All right. Skin conditions associated with venous insufficiency. Okay. Some of the skin issues that come along with chronic venous insufficiency, a lot of you probably already recognize, but just thought I'd put a few up on some slides there. The atrophy blanche, something probably a lot of you have seen, or you are probably thinking, whoa, I've seen that before. I just didn't know what it was called. Oftentimes this dermatitis or eczema, and a lot of times we will think that is cellulitis, and it's not. So that, that like flaking, dry, itchy skin, it's really hard to treat. It comes back like all the time. Very difficult to treat. Next slide. Here is lipodermatosclerosis. That is such a hard word to say. On the one slide that I had, where I was saying that was a good picture, and it had the leg off to the right. That leg was also a leg that had lipodermatosclerosis as well, kind of like inverted champagne bottle, they kind of refer it to as. In the middle, this chronic lipodermatosclerosis. You see a lot of legs that look like that. And here on the left, this acute lipodermatosclerosis. See how those legs look kind of red? A lot of times people will look at those red legs and think, oh, they have cellulitis, when in fact they don't. So I'll briefly be talking about that here momentarily. And then hemosiderin staining. I know that Dr. Mintz could probably talk about that for an entire day. But that is something that you'll see a lot of times in chronic CVI and, chronic venous insufficiency and venous disease. It's just, like this chronic, like purplish pooling, of basically like old capillary like blood. And it just kind of stays there. It looks like a stain on the legs. Okay, next slide. Some more interesting stuff here.
Hey, Josette, I'll add the
Yes.
hemosiderin staining for our
Yes.
providers. So sometimes patients think they have a tan, they don't have a tan. And again, it's the heme from the heme molecule that stains the skin because the blood just sticks around because it's not clearing easily. One thing
Right.
I just wanted to mention, patients think that if I fix their veins, that's going to go away. That's it. That does not go away. That's like a tattoo. So that's
Yeah.
not gonna get better, even if you're fixed. Just want to make sure people are aware of that.
Yeah, that's good to know. Yeah, that's good to tell your patients that too. Thank you. This is another hard word. Necrobiosis, lipoidica, diabeticorum. Boy, I needed to drink extra coffee today. This skin condition appears as a colored shiny scar with violet borders and can itch and scale. It's awful. It's linked to blood vessel inflammation related to autoimmune factors, as well as type 1 diabetes. So yes, if you see this, you definitely want to think autoimmune. But again, common with CVI. The other picture, I know that you guys have seen this a lot on a lot of maybe the older adult population. This is corona. Oh my goodness, I cannot talk today. Phlebectica. I'm sorry if I am like saying that wrong. If there's somebody out there that can say it better than me, please feel free to pipe in. This is classically described as the presence of abnormally visible cutaneous blood vessels at the ankle with 4 components: venous cups, blue and red, telangiectasis, and capillary stasis spots. Previous studies showed that the presence of CP is strongly related to the clinical severity of chronic venous disorders and the presence of incompetent leg perforators. Yes, I see this a lot in my 70, 80-year-old patients that have CVI quite often. And I'm sure you guys have seen it too. This is an interesting skin problem to have as well. This is pyoderma gangrenosum. Boy, and does it look like 1,000 other skin problems and ulcers. It is a skin condition that affects 1 in 100,000 people. It is also associated with autoimmune diseases such as ulcerative colitis, Crohn's, RA. It may have genetic component as well. It is also, unfortunately, associated with some cancers such as leukemia and lymphoma. It can start out as a red bump on the skin and then turn into an ulcer. They do not recommend doing anything of the kind with sharps. So don't debride, don't do surgery on this because it makes it worse. Moist, not wet, can help. Dressings of that kind. Steroids can help since it has very much an inflammatory condition. And like I said, it is triggered by skin trauma, cuts, punctures, that type of thing. So yeah, you want to be really careful with this. If you suspect this, I'd send them to a dermatologist. Okay, next.
I feel like I wish Amy Diamond was on this. I feel like she diagnoses this a lot.
I'm sure she does. Yeah.
Really? Because it's only supposed to be 1 in 100,000, and then seems like we put that diagnosis on a lot of patients. I think she uses steroid cream sometimes to make it better. But I'm not, I don't know.
Maybe she just sees, maybe she sees a lot of them. I've only had this in clinic maybe 2 times. Yeah. But when I did have it, I mean, I got the dermatologist involved, and I kind of worked with the dermatologist in treating the patient. You know what I mean? I got their recommendations on how to treat the patient, and we kind of worked together. Yeah.
I definitely don't want them to come see me.
Yeah.
I don't want that referral. Definitely.
Yeah, I don't blame you. I really don't blame you. Yeah. I understand. Okay, so now we'll talk a little bit about the venous ulcer itself. You can move on to the next slide. I really liked this one. This was also from the BMJ. Like this little picture, it shows you kind of the common places where venous ulcers are located, and arterial and neuropathic. Very handy tool there. Next slide. Again, this came from, I believe, I got this actually from the AAFP article, which I believe I mentioned later. I thought that was very handy. Kind of tells you about like their, characteristics of venous, arterial, neuropathic, and pressure. It said really basically among chronic ulcers refractory to vascular intervention, 20 to 23% of those ulcers may be caused by vasculitis, sickle cell disease, pyoderma granulosum, calciphylaxis, or autoimmune disease. So you see that sometimes these ulcers are even more complicated than what meets the eye. I mean, so many of these leg ulcers that we look at are not always like, oh, that looks like a venous ulcer, or oh, that might be an arterial ulcer. It really might be something entirely different. So you really have to be careful. Next slide.
Were you gonna
So
review like these a little? I think it's worth reviewing that chart if you like, or if you have pictures further down that show the different types. I can't remember.
yeah, I do have some pictures, and
Like
yeah, I do.
neuropathic versus arterial versus venous.
Yeah, I do have some
Okay.
pictures, I believe. Yeah.
Okay, just making sure.
Yeah, I think
Yeah, it's worth
so.
going over.
And if not, I'm like totally more than happy to send everybody a copy of this as well to definitely look at.
Well, we can go
I
back
just
too if there's time.
Okay. Okay. And then when in doubt, get an ABI. I just cannot stress that enough because you know, the ABI, you don't want to put compression on somebody that really may have no circulation at all, even if their leg is swollen. Um, you know, we want to keep in mind that you want to confirm that the issue is venous and not arterial, because sometimes you can be tricked. You want to keep in mind that if the patient's legs are particularly swollen or the skin is thickened, this can erroneously elevate an ABI score. And if you see that this may be a possibility, then you want to get toe pressures as well. This will help confirm arterial involvement. And if the toe waveform is flat or the value is less than 50, there is likely arterial involvement. So although arterial ulcers often have specific characteristics, sometimes they can have a venous characteristic as well. So you don't want to put compression on an extremity with an ABI of 0.5 or less. If you don't get an ABI, you won't know that. So you want to think safety first. I did include, like types of dressings for venous ulcers on this little table here. There are so many different types of dressings out there. It could overwhelm a person. And my advice to you is that you just try to pick a few that you like to use, like something that is very absorbative, and maybe maybe a couple that you like. And I would highly recommend a kind of 2-layer wrap, or maybe a couple of different 2-layer wraps to use on patients. And then maybe like a type of dressing that is kind of a moist dressing for the dry types of ulcers and that type of thing. You'll have to do a little bit of research on this. And I think also like getting in touch with reps that do wound care dressings are super helpful, because they'll give you free samples and then you can try them out. I think that's the best way to go. The next slide. This is also a really good resource from the BMJ on wound assessment and dressing choice for venous ulcers. That's super helpful because it kind of goes over like dressings that you might want to use for certain types of like dry or oozing types of wounds, and that is really helpful. Next slide. The 2-layer wrap, that is probably one of my favorite types of dressings to use on people with chronic venous ulcers. And there are like an abundant there are so many different types to choose from. I think my favorite one is this Coflex brand. Because it offers, I'm used to it the most, and I've used it the most. Coflex offers a dry type. It's like kind of a foam layer and then a Coban layer. And actually the little picture of it is in the bottom left. And so you can use this, and if you wanted to, you could put like a non-border dressing over the ulcer itself and then wrap the leg with it, and would give it some nice compression. They stay on really well, and they're so easy to put on. You can put this on in just a matter of minutes, and it's easy to remove. And oftentimes, home health can get them. Oftentimes patients can get them, through mail order. You can order it for them. They can stay on up to 7 days. So they're great. They also comes in a zinc form and a calamine form. So that's my favorite one. But believe me, the other ones are terrific too. You just kind of have to try them out. Yeah, I'm privy to the Coflex. Okay, next slide. This looks like so many different ulcers, but you must consider the patient's medical history. So this is a photo of calciphylaxis. This patient had end-stage renal disease. This wound would be mistaken, it could be mistaken, I should say, for a non-healing, venous, leg ulcer. It could be mistaken for a variety of different ulcers. But calciphylaxis has a 6-month mortality rate of 30 to 60%. So it would not be difficult to mistake a venous ulcer for an arterial ulcer. Sometimes their characteristics can be quite similar. So keep that in mind. Also keep in mind that VLUs, 20% of patients that have them also have PAD as well. So if they're not healing, get a punch biopsy or send the patient to dermatology for a biopsy to rule out skin cancers or calciphylaxis or, anything like that. Some things to keep in mind are excessive granulation tissue or elevated borders. That should be a little red flag for you as well. Next slide. Most common skin malignancies. These are some pictures of, I believe, basal cell carcinomas. But basal cell carcinoma, squamous cell carcinoma, and melanoma are common skin malignancies that you can get, that can come about from ulcerations as well. It's really scary. I mean, really, when I think about it, wound care is actually more dangerous. Like it has like some dangers to it as a clinician that, sometimes you don't even think about. Like a lot of bad things can, come out of it. Not just not healing the wound. I mean, patients can have skin cancer and you don't even know. Next slide. So make sure that, don't like sit on things, make appropriate referrals and don't wait. I say make those vascular referrals, the podiatry referrals, the dermatology referrals, have the patient follow up frequently, utilize your home health and your physical therapy, maybe even your occupational therapy. Definitely your lymphedema therapist, have them evaluate your patient if possible. Consult a dietitian, order DME equipment if appropriate, and definitely, compression garments too. Oftentimes your lymphedema therapist can help you with that as well. Next slide. And also, create a wound care box, for your patient, and yourself, or, a closet or a cabinet, in your, if you do family practice, like, however you want to do it, but, you should always have wound care, like a cleanser. If it's your patient and they have a very limited budget, even dial soap and water would work. And bleach wipes to clean surfaces, absorbent dressings, rolled gauze, tape, scissors, long ACE wraps, especially if you're doing that lower leg. MediGrip, that is like my favorite thing. Size G is what fits on most lower extremities. I will tell you, it's like $65 to $73 a box on Amazon, but it could last the patient for a really long time. I've had patients wash like a piece of, the leg part, and they hang dry it, and they can wear it over and over again. A box can last them a long time. And then silicone bordered foam dressings seem to be pretty good. It seems like a lot of people don't have reactions to that. Silver gel or Meta Honey, that can be kind of helpful for the more dry types of wounds. But I will tell you, if you get the Meta Honey, like outside of those wound borders, it can macerate wounds. So be extremely careful and make sure they don't have an allergy to bees. Silvadene is really helpful. I've always liked that one, but make sure they're not allergic to sulfa drugs. And like I said, ideally the 2-layer wraps, you should definitely have those in your clinic. And then how to get your patient help on the next slide. Again, the lymphedema therapist, golden. Lymphedema pumps, I'll tell you, if you can get with, a vendor that does lymphedema pumps, and Google them, they will come to you, believe me, and they will help you figure out like the documentation. They will help you get them for your patient. It's really, really handy. They're a lifesaver for your patient. They can get your patient's legs pretty skinny. They're wonderful. An hour a day with the lymphedema pumps with a motivated patient and some lymphedema garments can make a gigantic difference. And then, of course, the lymphedema garments. I really like the Velcro kind Sigvaris makes one called the CompreFlex, and kind of like in that picture on the slide, very easy to get on and off for patients. It really keeps them consistent in their wear. And then, of course, a vascular surgeon like Dr. Mintz. All right, and then next slide. This is just a list of really, really good mail order wound care supplies, and they also do compression. Those are their websites. I think in some cases you can just create an account and then put in your patient's information and send it off, and your patient will get it directly to their home. They do accept, some of these places accept private insurance, all of them do, Medicare and Medicaid. Some of them do accept West Virginia Medicaid. Next slide is some of my favorite compression garments. And Compression Guru is like my favorite website. If your patient just wants to say, hey, I want to just buy the compression myself out of pocket, you're probably looking like at about maybe $100 or close to that. Sometimes a pair, sometimes a leg. But if they can afford that and not go through all the hassle of insurance, that's fantastic. So then we have our case studies, and I just have a couple. So this patient was a new patient. She was about 55 years old, and she had not been to a doctor in years. And I do mean years, like maybe 15, 16 years. She worked in an office, and She sat at a desk all day, and she was a very shy person. She was too embarrassed to see a provider about this and had been treating this wound herself for years. And she said it probably had been about 15 years. It started out as a red red bump on her leg. And I sent her to a dermatologist, and the pathology turned out to be a basal cell carcinoma. Next slide. So this basal cell carcinoma, or the basal cell layer, is found at the bottom of the epidermis, and they produce new skin cells. And then it turned into a squamous cell carcinoma that eventually metastasized. Usually these develop on the sun exposed areas. It increases with age. She's fair skinned, with a family history of skin cancer. I think she had a brother that also had skin cancer as well. And she actually had multiple places on her arms as well that they had not in any way developed into this. Yeah, you could go to the next slide. That's fine. What was so crazy is the same lady was wearing a turtleneck, and she always wore a turtleneck to work. And she's like, well, I've got something else I want to show you. And this is what she had. And this turned out to be a nightmare. I sent her to an ENT doctor for this. And this was cancer. And she actually turned out to have breast cancer. I shortly left my job after the, after that, but this did have some basal cell carcinoma in it, but it was actually pushing on her trachea. So, I mean, this was really, really like serious stuff. She said it had started out as a small red, pink, like papular type of lesion, and it just kept growing. It bled really easily, and it was, yeah, I've never in all my years ever came across anything like this. But yeah, I don't know if she is still living. But yeah, I mean, I cannot stress enough. People need to see their family doctor at least once a year. Yeah, she waited way too long. So, okay. This next case, I bet a lot of you have seen legs like this. This is a 60-year-old female with a past medical history of obesity, type 2 diabetes, chronic kidney disease, congestive heart failure, COPD, hypertension, history of smoking, hyperlipidemia, and osteoarthritis. She has had edema in her legs for years, and it's been worsening in the last year or two. Now it's draining in the past couple months, worse in the last 2 weeks, painful in the last 4 to 5 days with heavy drainage. It's kind of a little bloody, a little purulent, like a slight odor. Her leg is warm, erythematous, painful. Like I said, heavy drainage, kind of serosanguinous, slightly malodorous, little purulence. Oh, I keep losing my. What do you think the diagnosis is? Anybody? It's pretty easy. And she's not allergic to anything. How might you consider treating her? What tests might you order? If your vascular department is totally available right now, and maybe like what kind of dressing might you try for a patient like this?
Talking to our primary care colleagues here. Anyone want to answer? How would you treat this patient?
Sorry.
Oh, you're fine. You're fine.
Okay, there we go. Does anybody have any recommendations that they want to chime in on?
Crickets.
Dr. Brubaker just came off mute. Perhaps he wants to say something.
Yeah, it seems like you have an infection, at least currently, if you're prevalent and hot.
Yes.
Right? And then as
Exactly.
far as the underlying, if it's just real severe insufficiency or
Yeah.
anything else that would be causing lymphedema per se.
Right. Yeah. You might want to treat it with like antibiotics, if needed, or might be cellulitis or exactly. Yeah. Thank you. Thanks for answering that. Okay. I know we're like totally running out of time here.
Do you want me to go to the next one real quick?
Maybe skip it. I just wanted to show you like the resources for your clinic. There is a whole list of like websites and books and conferences. And then let's see. Definitely take advantage of them. The journal that I really like, Advances in Skin and Wound Care, is really good, and it's not expensive at all. And then the two books I would like completely recommend for your clinic would be Wound Care Essentials and The Clinical Guide to Skin and Wound Care. They are like, if you don't even really need anything else, I mean, those two books will walk you through just about anything. And then, Wound Source is an awesome website. It will give you so much information. It has like all kinds of white papers on wounds. Just, feel free, like just take advantage of all this stuff, guys, because it's available to you. And then the next slide just has, more information for you. I just wanted this all to be available to you guys because I think everybody should be able to take advantage of what's out there to just, make yourself, I can't say smarter because you guys are already smart, but you know what I mean? Just to, just have more tools in your toolkit. So, yeah, so I hope that helps. Thank you so much. I'm sorry I just talked and talked and talked, but thank you so much for your time. Those of you that showed up, I really appreciate it. This is probably my favorite subject in the world. So thank you.
Well, thank you for presenting today. You did a very good job.
Oh,
Um,
thanks. Appreciate it.
Thank you very much.
Oh, thank you. So nice to see you. Thank you.
So I just want to give a reminder that our upcoming session, the next one will be June 18th, and it'll be on multidisciplinary limb preservation. This is in team. So
Thank you.
I hope to see you all then. If you guys need anything, feel free to reach out in the meantime.
Thank you so much.
Thank you so much,
Everyone.
Gisette.
Thank you, Josette. Great
Thanks.
job.
Oh, thank you. You have a great day, everybody.
Thank
Bye.
you.